Good morning, everyone. Welcome to Understanding California Birth Options webinar series. This is part 2, Envisioning Midwifery, Integration, Collaboration, and Expansion. We're so happy to have you all join us this morning. Next slide, please. This webinar will have Spanish interpretation available. So I will pass it to our interpreter, Edna, to give the instructions on how to turn on your interpretation.
Thank you, and hello everyone. I'm going to be providing instructions first in Spanish and then I'll follow in English. Hola a todas y todos, buenos días. Vamos a tener interpretación simultánea disponible y en un segundo van a ver en su parte baja de la pantalla, si están en una computadora, que va a aparecer un icono que dice interpretación. Una vez que aparezca, por favor, presione y seleccione el idioma de su preferencia, ya sea inglés o español, y también mute original audio o silenciar el audio original. Si está en un teléfono o una tableta, va a haber 3 puntos o donde dice more o más, presione, seleccione language interpretation, después el idioma de su preferencia, ya sea inglés o español, y también mute original audio. Si cualquier motivo tiene problemas con esta función, siempre puede regresar y presionar donde dice unmute original audio, y si tiene problemas técnicos nos puede dejar saber a través del chat. So hello everyone, in just 1 second, we're gonna enable the interpretation function. If you're on a computer, you're gonna see an icon appear at the bottom of your screen. It's not there yet, it will appear once I'm done with instructions. And again, once it's there, just click and select the language of your preference, either English or Spanish, and also mute the original audio. If you're on a mobile device or a tablet, you're gonna see 3 dots or where it says more, click and select the language of your preference and also mute original audio. And if you're having any issues with the function, you can always go back and unmute the original audio or send us a message through the chat. Thank you.
Thank you so much, Edna. So now you should see in a minute, you should see the globe icon at the bottom of your screen. Go ahead and press that and then select the language that you would like to listen to the webinar in. And the panelists will also have to select this as well. So I'll give you all a few seconds to do that. Thank you. This webinar is presented by the Whole Child Equity Partnership. A whole child approach envisions a society rooted in racial and economic justice, where all children are embraced, valued, and cared for, where every Black, Native American, Asian American, Pacific Islander, and Latinx child and their family has access to systems and services that promote their health, well-being, and the life opportunities that enable them to thrive. The mission is to advance a collective whole child equity agenda that seeks to improve the conditions under which children develop, learn, live and play, celebrate, and value their strengths and attributes of their racial, cultural, linguistic identity, and support their sense of belonging. And to the right, you'll see some logos of all of the organizations that are a part of this coalition. And if you would like to learn more, I'll have someone drop the link to the Whole Child Equity Partnership website in the chat. Introductions. Go ahead and introduce you all self in the chat. Please tell us your name, where you're calling in from, organization, and title if you wish. And who we are. My name is Ebony Durham. I am the Senior Community Engagement and Advocacy Associate at the Children's Partnership. You have Yuli Smith, who is the co-founder for Around Birth Collective. Tristen Orosco, who is a licensed Indigenous midwife and co-founder of Around Birth Collective. And we have AJ Jordan, who is a student midwife. Thank you all for joining. Hi, Connie. Hi, Kelly, Linda, Rita. Thank you all for joining. Keep introducing yourselves in the chat. Now I'll introduce our panelists. Yuli Smith, her pronouns are they, she. She is a mother of three, a midwife licensed by the Medical Board of California, and an internationally board-certified lactation consultant, co-founder of Around Birth Collective and program manager at Global Communities Healthy Start, with nearly a decade of experience in prenatal and infant health field. Yuli's work has centered on preserving and expanding access to midwifery care, improving prenatal outcomes, disrupting binaries, and queering midwifery praxis. Her communities of focus include people of global majority, LGBTQ2S+ kin, immigrant communities, and survivors of sexual and domestic violence. Next slide, please. Tristen Orosco is a Kawish mother of two, a wife, a basket weaver, a Kinney cat, which is a midwife. She lives in part of the traditional Kawish homelands. She has a BA in American Indian Studies from San Francisco State University. She has a BS in midwifery from Midwives College of Utah. She's a certified professional midwife, North America Registry of Midwives, a licensed midwife by Medical Board of California, owner and a Kinney cat at Timacu Midwifery, and the co-founder of Around Birth Collective. And we have AJ Jordan, who is a Black woman, autistic, and neurospeed, LA native, boy mom, a Marvel fan, and a homeschooler. She is a student midwife in her third and final year at Midwives College of Utah, currently apprenticing at Tourmaline Birth and Wellness Collective in San Diego. AJ will be graduating in April 2025, anticipating her license by May 2025. She earned her BA of Communications at Prairie View A&M University, an MA of Entertainment Business at Full Sail University, and she is an advocate for Black infant and maternal health and the founder of Sanka Baby. And now I'll be going through our agenda. Next, we'll have our presentation by Yuli, Tristen, and AJ. They will be talking about maternal and infant mortality crisis in the US and California, disparities including racism, accessibility, closures of L&D. They will be going over midwives in California. And lastly, there will be a call to action for finding solutions together. After that, we'll open it up for Q&A from all of you. We'll go over some resources and then stay to the end for our evaluation. You will be entered into a raffle and we will be able to pick 3 winners from the raffle. So you don't want to miss that. Next slide, thank you. Some announcements for you. We are recording this webinar, and a recording of this webinar will be provided to everyone at the end of the webinar. Q&A, if you have a question, please drop it in the Q&A Zoom box. There will be an audience Q&A portion at the end of the webinar. For closed captioning, click the live transcript button from the in meeting Zoom toolbar and select one of the options from the menu below, from the menu. And now I will kick it off to our panelists. Yuli, go ahead.
Thanks, Ebony. Welcome all. Thank you all so much for being here and sharing this space with us today. I feel very honored to be here with you and to be with my co-speakers, Tristen and AJ. And shout out to the Children's Partnership and the Whole Child Equity Partnership. We adore you all from ABC. So, welcome to our Envisioning Midwifery Integration, Collaboration, and Expansion webinar. I'd like to first lay out the current scene of maternity care and perinatal outcomes in the US and California. So I'll be kind of toggling between the US statistics and California statistics, and we'll compare the two. Okay, so bear with me. The first half of this presentation is pretty statistic heavy. Please drop your questions in the chat if you need any clarifications. Also think about, because we want the end of this webinar to be more collaborative and less lecture-y. So think about these statistics. Think about the approaches that we're going to be diving into, namely the medical model and the midwifery model of care. And then we'd like to pose to you some questions at the end of the webinar. So write down any notes you need to, drop your questions in the Q&A box. We're really excited to work together to improve birth outcomes in California and also the US. So in 2023, here in the US, birth attendants predominantly were physicians. So predominantly physicians, whether they were MDs or DOs, attended about 86% of births. And largely physicians attend births inside of a hospital. So over 97% of births in the US occurred in the hospital setting. Within the hospital setting, about 11% of births were attended by certified nurse midwives or CNMs. I'm also going to be using a lot of abbreviations. So MDs, DOs, those are our physicians, our OBGYNs, our doctors. And then CNMs or CMs are our certified nurse midwives or midwives that typically have privileges inside of a hospital. When I reference our other types of midwives, which are CPMs and LMs, that stands for Certified Professional Midwife and Licensed Midwife. In this presentation, when Tristen takes over the other half, we'll be really focusing in on licensed midwives here in California. Okay, but across the US, only about a little less than 2% of births occurred in an out-of-hospital setting. So that means the birth occurred either at somebody's home or in a freestanding birth center. And a freestanding birth center is a birth center that is not attached to a hospital system. Okay, and largely those births are attended by midwives, CPMs, LMs, or other birth professionals, whether they be traditional midwives, birth keepers, and so on. Okay, so next slide, please. So birth attendance in California, the most recent statistics we have are from 2021. 98% of the births occurred in the hospital. And very similarly to the US statistics, about 86% of those births were attended by a physician, and the others inside the hospital system were attended by certified nurse midwives. About 2% of births occurred in an out-of-hospital setting, and of this 2%, about 62% of those occurred at home, and 30% of those occurred at a birth center, likely with an LM or a CNM. Okay, next slide, please. Thank you. Now, the US, let's see. Actually, did we skip a slide? No. Okay, I think we're here. That's good, thank you. Now, the US in total, when we're compared against our high income peers, other high income countries, our industrialized countries, amongst the top 10, the US ranks last. US ranks dead last when it comes to maternal mortality rate. So maternal mortality rate means mothers who are dying, birthing folks who are dying soon after birth or in the perinatal period. And that could be related to birth, a pregnancy complication, or it just means that they are in that perinatal period. And perinatal means around birth. So before birth, during birth, right before birth or preconception, during birth, and in the postpartum period. Okay, in the US, we rank 55th amongst all countries for the maternal mortality rate and 51st for the infant mortality rate. Okay, so to give you some perspective on that, that means that our national overall maternal mortality rate ranks very similarly to countries such as Lebanon, China, Iran, and Malaysia. Okay, next slide, please. Now, this graph demonstrates how the US ranks compared to similar high-income countries. Okay, so you can see the US is at the very far right of this graph. And the numbers you see are the amount of deaths that occur per 100,000 live births. So the US ranks about 22.3 deaths per 100,000 live births. That number almost triples when we look at Black women and Black birthing folks in the US, which is the very last column on our bar graph here. Now, interestingly, the countries that are on the further left side of the graph, the ones that have the lower maternal mortality rate, they actually have a long history of integrating midwives in their healthcare systems, as to where the US, Canada even, has a lower amount of any type of birth assistance or birth attendance available to birthing folks. And midwifery integration is not a high priority here in the US, unfortunately. Okay, so countries that have the highest supply of birth providers, whether they're OBs, doctors, midwives, they have better outcomes. Now, the US, with less midwifery integration, we have worse outcomes. And interestingly, at the state level here in the US, states with less midwifery integration actually have higher instances of Black people giving birth. So that's an interesting note. And here I would also like to take the opportunity to clarify that these outcomes have nothing to do genetically with Black folks dying. There is nothing different between Black folks and their white peers. This almost 3 to 4 times increase in the maternal mortality rate that we're seeing is absolutely correlated with racism and institutionalized racism here in the US. Okay, that trickles into the care that is given to Black folks when they're giving birth. Next slide, please. So the most recently available US and California statistics track pretty closely with one another. I would say that California is one of the best states in regards to pregnancy-related mortality. So pregnancy-related mortality means that a death occurred because of pregnancy or because of a complication that had stemmed from pregnancy. It's a little more specific than the maternal mortality rate. Okay. California does rank better in regards to other states within the United States, but this number is still appalling. Okay. Now, our top causes for maternal mortality and or infant mortality in California relate to infection, sepsis, for birthing people, cardiovascular diseases, hemorrhage. Okay. I would also like to note that in the previous data set that was distributed from 2017 to 2019, one of the top causes of maternal or pregnancy-related mortality was actually mental health. Now, for these most recent statistics, mental health is not included, though it is still an issue. And in 2017 to 2019, mental health accounted for 22.7 pregnancy-related deaths. Okay. We have made big strides here in California in regards to hemorrhage. We do see that causing less deaths. So that is a plus. That is some progress that we've made over the last few years. Okay. And interestingly, for infants, some of our top causes of infant mortality, so a baby passing away from birth and within the first year of life, are birth defects, preterm birth, low birth weight, sudden unexplained infant death. Okay. Those are very similar in the US and here in California. Next slide, please. Okay, this is like lots of numbers, lots of bars, but I will explain this graph for you. So this graph is tracking our pregnancy-related mortality ratio by race and ethnicity for the US, which will be in purple, and for California, which will be in pink. Okay, we use the most recent statistics that are available. So for the US, this is 2020. And for California, it's between 2019 and 2021. Okay. And you can see here for California, there are no statistics gathered for American Indian or Alaskan Natives. Okay. And also there's no statistics gathered for multi-race when it comes to pregnancy-related mortality ratio. Okay. That does not mean that they're not occurring. It means that they just weren't accounted for, and or in the case of Indigenous folks, American Indian and Alaskan Native, there wasn't enough occurrences that happened. I believe the threshold needs to be 10, and it did not meet that threshold. But that's still a significant number given the population of Indigenous folks here in California. Okay, next slide, please. Now, this slide demonstrates all of the pregnancy-related deaths that occurred in the postpartum period, which 65% of all pregnancy-related deaths occurred in the postpartum period. 2/3 of pregnancy-related deaths occurred within 42 days after birth, while a little less than half of the deaths that occurred in the postpartum period happened after 6 weeks. So that is really important. And I'd also like you to think about when do people typically get care in the postpartum period? Okay, what happens after 6 weeks? Do they have any more visits? Do they have any visits before the 6 weeks? So we'll keep that in mind as we continue on with the presentation. All right, thank you so much. So these were some findings that I found fascinating and wanted to share with you all. It's the results from a California survey that gauged clinician care priorities and practices in the fourth trimester. And the fourth trimester is the first 3 months after you've given birth. So the postpartum period. Okay. OBs, which are doctors and midwives, differ in their approach according to this study and these results. When it comes to postpartum care, OBGYNs are more likely to limit patients to only one visit in the postpartum period. So about 46 percent of folks only get one, or I apologize, most folks, because most folks are being seen by OBGYNs, are getting only one visit in the postpartum period. Okay. As to where midwives often have more visits, and their visits are typically longer, but midwives tend to struggle with addressing the social drivers of health more than OBs do. Okay. So, despite longer initial visits, midwives' model of care typically includes multiple postpartum visits, and they emphasize a relationship-centered approach that may allow them to open up and to gather more information specifically and address specifically the social health components in later visits. This was only looking at the first visit in the postpartum period. Okay. Next slide, please. So based on that study, the variation in care priorities suggests that perhaps a collaborative approach with midwives and OBGYNs and leveraging their strengths could help close gaps in the postpartum period and hopefully prevent pregnancy-related deaths in the postpartum period. And to just review, because we're going to switch off to Tristen soon, just to wrap up all these like really heady statistics for you. Most births in the US and California take place in the hospital, which means they were attended by a physician. So most birthing people are receiving the medical model of care throughout the perinatal period. So in the prenatal period and the postpartum period. And the US has an appalling maternal mortality rate compared to our peers. California is doing slightly better in regards to maternal and infant mortality, but the numbers are still unacceptable. And due to systemic racism and a legacy of colonization, Black and Indigenous folks face the worst perinatal outcomes. And with that, I'll pass it off to Tristen, and she has some really great information to share about midwives with you.
Hello, everybody. So, what is a midwife? It is probably one of the top questions midwives get asked when talking about midwifery. A lot of people confuse a doula with a midwife and a midwife with a doula. And while many midwives were doulas before becoming a midwife, we're not the same. Doulas provide emotional and physical support, where midwives are trained medical care providers. Next slide, please. So this definition by the International Confederation of Midwives, I think really highlights and encompasses exactly what a midwife is. The midwife is recognized as a responsible and accountable professional who works in partnership with women to give the necessary support, care, and advice during pregnancy, labor, and the postpartum period, to conduct births on the midwife's own responsibility, and to provide care for the newborn and infant. This care includes preventative measures, the promotion of normal birth, the detection of complications in mother and child, the accessing of medical care or other appropriate assistance, and the carrying out of emergency measures. The midwife has an important task in health counseling and education, not only for the women and gender diverse people they serve, but also within families and communities. This work should involve antenatal education and preparation for parenthood, and may extend to sexual and reproductive health care and care for young children and infants. Next slide, please. So midwives follow the midwifery model of care. As Yuli mentioned, it varies quite differently than the medical model that is followed within a hospital-based system. The first is continuity of care. So the midwife is the care provider throughout the entire pregnancy, during birth, and postpartum period. Now, this can vary depending on if it is a group midwifery practice, but relatively, they will still try to really fall close to the continuity of care part of the model. The continuity of care really helps foster a trusting relationship between the provider and their clients. So my clients trust me and I trust my clients, and this helps when we're talking about number 2, which would be informed choice or informed consent. We give evidence-based information and are able to have conversations and have shared decision-making conversations around the risks and benefits of every option that is available, while also taking into consideration cultural and personal beliefs that is very valid within those conversations. Number 3, the minimizing of interventions. We are low tech and low intervention for the majority of the time. Of course, if the safety or if there are any red flags that are arising within the pregnancy, birth, or postpartum period, then of course we're going to, implement medical interventions in order to ensure the safety of the client and their baby. Number 4, holistic care. Physical care is really important. Vitals and measuring, monitoring the growth of the baby is incredibly important. And we also factor in, emotional, spiritual, and psychological well-being of our clients. We do heavy counseling on nutrition, probably at every appointment. We screen for mental health. We screen to determine what environment the person is living in, what chronic stresses that may be affecting them and their pregnancy. And we look at social support too. If anything arises, we are trying to address those barriers for our clients. 5, individualized care or personalized care. We recognize that each person and each pregnancy is unique, and care is tailored to meet the individual needs of a family. We are factoring in their cultural preferences, their cultural teachings around birth and pregnancy. And we want to be able to factor that in when we're talking about informed choice. And lastly, respect for physiological birth. We trust the body's ability to give birth and support that process along the way, while and respecting the person's autonomy and their preferences, while also recognizing that complications can and do arise. We have the means to be able to address those things if needed. Next slide, please. So there are a few different types of midwives within California. We have licensed midwives, certified nurse midwives, and lay midwives or birth keepers. Earlier, there was a credential called a certified midwife that is recognized in other states, and they do have the ability to work in the hospital setting. However, in California, that credential is not recognized. So for licensed midwives, we are governed by the Medical Board of California. We are we mostly practice in a home birth setting or a birth center setting, though our licensure does not say or prohibit us from practicing in a hospital. In fact, there are some licensed midwives that have had hospital privileges in parts of the state. Most of the licensed midwives in California went to a NEAC accredited school, which is anywhere from 2 to 4 years. They took a national exam and were able to get licensed in the state. Now, certified nurse midwives are governed by the Nursing Board of California, and they can be found in hospitals, birthing centers, and at home as well. Now, the pathway for nurse midwifery is to go to nursing school, and then you would go on to get a master's degree in midwifery. So this whole process is about 6 years, give or take. There are also lay midwives or birth keepers that are within the state. They are unlicensed and they would be in a home birth setting. Next slide, please. So because we are licensed midwives, we're going to be focusing on our scope of practice and what the state has outlined for us. So next slide. This is just a snippet of a much larger document. Our regulations are found in the Business and Profession Code. So if you would like to look it up, the information is in the top right to be able to do so. But just some highlights of generally what the licensure says is that a person has to be low risk in order to enter into midwifery care. So no pre-existing medical conditions, no heart disease or heart conditions, no chronic hypertension or diabetes, and so forth. The birth has to occur between 37 and 42 weeks. Anything outside of these would be considered higher risk, meaning there needs to be a little bit higher amount of technology potentially used and would be best served in a hospital-based setting. The pregnancy has to be a singleton head-down baby, so unfortunately no twins and no breeches. And those that develop conditions in pregnancy like unmanaged gestational diabetes, hypertension, preeclampsia, cholestasis, and so forth would require consultation and transfer to a physician. Again, nowhere in our licensure does it say we cannot work in a hospital and continue that continuity of care for clients. There are some licensed midwives that have had privileges to work in hospitals in the state. Next slide. So evidence on midwives, I pulled a few different studies to just quickly highlight the benefits of having a midwife, and it shows within the evidence. So the first study is the outcomes of care for 16,924 planned home births within the United States through the MANA Statistics Project. This is the largest home birth study conducted within the United States. So of that 16,924 births, 89.1% completed a home birth. 93.6% completed a vaginal birth. So even if they transferred to the hospital, they were still able to have a vaginal birth. 87% completed a vaginal birth after cesarean section. So those that were attempting a VBAC, 87% were successful in that. There was a 5.2% C-section rate. And when you're looking at the C-section rate in comparison to the United States and California, it hovers around 30%. Those that did transfer to the hospital, less than 5% needed to use Pitocin or an epidural. Study 2 is looking at 10 years of publicly funded home birth service in Victoria and looking at the maternal and neonatal outcomes. Now, this is out of Australia. And in Australia, home birth only accounts for 0.3% of all births. So of the births that were funded over 10 years, 86% had a home birth. 13.9% transferred before the birth for various reasons. So this could have been during the prenatal time or at some point during the labor before the baby was born. And 8.2% transferred in the postpartum period. Overall, they found lower rates of episiotomies and need for suturing, less active management, and less blood loss overall. The third study looks at the potential impact of midwives in preventing and reducing maternal and neonatal mortality and stillbirths. This model was implemented, it's like as a theoretical in 88 different countries, and the United States was not included as one of the countries. So compared to how things are now, if there was a big increase in midwife-provided care, this could prevent 41% of mothers' deaths, 39% of newborn deaths, and 26% of stillbirths, saving 2.2 million lives each year. Now, if there was only a small increase in midwifery in these 88 countries, this could prevent 22% of mothers' deaths, 23% of newborn deaths, and 14% of stillbirths, saving 1.3 million lives each year by 2035. Now, the World Health Organization has come out and said that if midwifery was integrated into all of our healthcare systems, this could prevent 80% of all maternal deaths, stillbirths, and neonatal deaths. Quality midwifery care improves over 50 other health-related outcomes, including sexual and reproductive health, immunization, breastfeeding, tobacco cessation and pregnancy, malaria, tuberculosis, HIV, and obesity, postpartum depression, and could help promote early childhood development. Now, the last study is looking at the continuity of care model versus other care models for women and their babies. And so this looks at 17 different studies made up of 18,533 women in Australia, Canada, China, Ireland, and the UK. These people were considered low risk at the start of their pregnancy, and if a complication of some sort arose during pregnancy, birth, or the postpartum period, midwives continued to provide midwifery care in collaboration with specialists and other obstetric teams. They found that people who had the continuity of care of their midwife still in care, they were less likely to experience a C-section or instrumental vaginal delivery. They may be less likely to experience an episiotomy and more likely to experience a spontaneous vaginal birth. It probably made little to no difference in having an intact perineum or preterm birth, and people were more likely to report positive experiences. And they also found a cost-saving benefit. Next slide, please. So the maternity care deserts is another crisis that we're facing within the United States. The definition of a maternity care desert is an area without a single birthing facility or obstetric clinician. And they defined obstetric clinician as a doctor or a certified nurse midwife. 35% of US counties are maternity care deserts. More than 2.3 million people of reproductive age live within these areas. Over half of the counties in the US do not have a hospital that provides obstetric care. And in 2021 to 2022, approximately 1 in 25 obstetric units closed nationwide. So as you can see to the graphic to the left, red would be considered a maternity care desert and gray is considered full access. Now, if you look at California, you're like, it doesn't look so bad, but the thresholds that they are using to define full access don't make sense when you're comparing larger counties with smaller counties or lower resourced areas with higher resourced areas. So the threshold for full access is 2 or more hospitals or birthing centers and 60 or more obstetric providers within an area. So in California, 6.9% of counties are defined as maternity care deserts. 9.2% of birthing people receive no or inadequate prenatal care. These statistics are higher for Black and Indigenous populations. So for Black families, 14% of birthing people receive no or inadequate prenatal care. And for Indigenous families, 21% receive no or inadequate prenatal care. Now, there was a 21.7% decrease in the number of birthing hospitals between 2019 and 2020. In San Diego County alone, 2 birth centers and I believe 2 hospitals closed within the last year and a half or so. So like I mentioned, you cannot compare counties like San Bernardino County, which is the largest county within the United States, with a county like Orange County that is much smaller, with the thresholds that they have included to define full access or maternity care desert. It just doesn't make sense. Even in higher resourced areas like Orange County or San Diego County, there are still people within these counties that are considered unassigned, meaning they still do not have access to a maternity care provider. And so they are not receiving adequate care. Next slide, please. So addressing maternity care deserts through midwifery. We are certainly not the only solution to this, but we can be a part of the solution. So midwives are really great at figuring out logistical barriers, whether that be transportation insecurities or economic insecurities. We can be pretty resourceful for the most part. A lot of midwives offer home visits. Now some offer home visits for every visit and some offer just a handful. A lot also offer telehealth visits as well. Now, this becomes really important, especially in the postpartum period. It is the most neglected part of the childbearing year. And we know this because most of the bad outcomes are occurring in the postpartum. So for midwives, we typically offer 3 to 6 visits just within that first 6 weeks postpartum. And we're assessing the physical, environmental aspects of a person, the mental health screenings. We're looking at breastfeeding. We really want to make sure our clients are not going to be falling through the cracks that the healthcare system is experiencing right now. I know myself and Yuli also offer extended postpartum care. So after the first 6 weeks, we continue to see our clients at 3, 6, 9, and 12 months. We want to make sure our clients are good and that they are supported and that they have access to the resources. And it allows us to have our eyes on them because the postpartum period is it's a really difficult time. It can be for parents, especially new parents. Number 2, a larger practice area. We surveyed a few midwives in our area, and it seems that their radius is anywhere from 1 to 2 hours. So midwives are traveling pretty much wherever they are desired to meet clients where they are at. This allows for us to address maternity care deserts. There are midwives that are offering only prenatal care for folks in areas that have lower resources. Those folks then go to the hospital and transfer their records. And then when they go home, the midwife picks up the care for that first 6 weeks and beyond. 3, cost is significantly lower in comparison to a hospital birth. We offer sliding scale, payment plans, various options. Now, insurance is kind of a hot topic in midwifery right now. Many do not accept insurance because of various reasons. One being that the payout is less than half the cost that the midwives are charging, and it's just not sustainable for midwives to accept insurance and also wait 4 months to get paid for a birth that occurred months prior. Also, malpractice insurance costs is incredibly expensive for midwives, and so that is also a barrier. And 4th, creating more midwives, especially midwives of color. We really need to support and fund Black and Indigenous midwives to be able to become midwives to serve their communities. Midwifery school is very expensive and closures are happening across the United States. In California, there's only now one available school for the nurse midwifery pathway, which is Cal State Fullerton. UCSF just put their midwifery program on hold and is switching to a doctorate program for midwifery, which is going to make midwifery inaccessible and make the process much longer for nurse midwives to become a nurse midwife. San Diego State University has suspended their nurse midwifery program as well. There are 0 schools based in California for those that want to go the licensed midwifery pathway. So the only options to become a licensed midwife in California is to go to a hybrid schooling program or to move out of state. So both are barriers. It's not possible. It's very, very difficult. Being a student is a very unique experience, and so I'm going to hand it over to AJ to share their experience as a Black student midwife.
Hey everyone, I hope that you guys can hear me. Thank you, Tristen, so much for all of that wonderful information. So for my portion of the presentation, I'm going to be specifically talking about my experience as a Black student midwife, because it is very different from a lot of other students that I get to sit with in my cohort. So here's my perspective and experience. So here, these are the things that I pretty much believe circle what it looks like to be a student midwife. The first thing we're going to talk about is accessibility. Some of the barriers that I face as a student midwife as far as accessibility are concerned is that it's really difficult to find preceptors. My school in particular has a semi-rigorous process that preceptors have to go through as far as being verified and approved through my school to be acknowledged as a preceptor. So this is, and I'm sorry because I'm kind of talking and not really telling you guys what these things are, but a preceptor is a licensed midwife that I, as a student midwife, will work under to get all of my hours that I need to become a licensed midwife per the requirements by NARM. So one, like I was saying, it's really difficult to find preceptors. And then a lot of times when you're looking for a preceptor, you have to find one wherever you can find one. So a lot of students are either having to pick up their life and move to other states or other cities, or having to drive very long distances to get to a preceptor just so that they can complete their schooling. In addition to that, you might find a preceptor that's not busy enough so that their clinic work might not be in alignment with either how quickly you're trying to complete your didactic work. So for myself, my program alone allows us to take up to, it's about a 4 to 7 year program. I am going through a bachelor's degree program, which is not common for most MEAC accredited midwifery schools. I think Bastyr is another one that has the bachelor's program as well. So for my particular situation, sometimes they're just not busy enough, right? So you're having to either travel very long distances, and then in addition to that, trying to find multiple preceptors if that's necessary. So I'm finishing a 4 year program in 3 years because I just decided that committing suicide was a great idea. But and then there's some students that even if their goal was to finish within the 4 year time frame, they're having to extend that time to 5, 6, 7 years because of lack of availability of preceptors within the area. You know, people have children, life, things just happen. So considering these things, now we're talking about the work-life balance of a student midwife. For me, the thing that's been the most challenging is so I'm also a homeschool parent, right? So I'm having to homeschool my kids. And yes, that was a choice that I made, but I was homeschooling prior to me starting midwifery school, which is also a part of why I'm pushing myself so hard to finish much sooner than later. But it's really difficult to do homeschool, do my own school, and then also even finding time to work. It's like impossible to do those things. So finding the ability to be able to go to school and do my internship is really difficult because my internship is rigorous. My course load for school is also rigorous. So I'm not sure how much of you guys know, but basically my internship as a midwife It's pretty much the equivalent of like a student who's going to school for nursing or a doctor, where they're required to have a residency before they can actually be licensed or certified with the medical board in whatever state that they're in, right? So my internship is a residency as a midwife that is required in order for me to get my license. So being that it's required, and my didactic work with my school runs concurrently with my internship. So the way that my school is broken up is in 3 different phases. The first phase is your observe, where you're kind of just sitting in the room, acting more like a doula. Our second phase is the assist phase, where we're much more hands-on. And the third phase, which is what I'm in right now, is primary. So you are acting as the primary midwife while your preceptor is basically just in the room supporting you, and then just making sure that you're staying and doing the right things to sign off on all of your things. So I have to do all of my stuff at the same time. Now, there are some students that are not going through a bachelor's degree program, or sometimes it's just set up a little different where they can kind of do their didactic on their leisure and kind of figure out how that works for them in their own environment and then get their numbers. Like, I know that there's some students that don't go to my school, but that I've had the opportunity to work with, that they've completed their numbers, but their schoolwork hasn't been complete yet. So it's almost strange for me because I'm just used to, I have to do everything at the same time. And if I don't complete my numbers in conjunction with whatever phase I'm in for schooling, then I can't move on to the next phase. So I can't move on to take my classes for phase 3 because I haven't completed my numbers for phase 2, even if I have completed my course load for that portion already. So with that also being said, as a student midwife, I have to be accessible. So the birth center that I'm at, our system is set up in a way where every midwife has a student, but if my preceptor is on call, I'm also on call. So if she gets a call that there's a birth, I'm expected to be able to get up and just go, right, to be available for that birth. And so understanding this, it makes it really difficult to work and to have any sorts of income outside of really being a student, because I have to be where I have to be. Babies come when they come, and I need to be available, whether it's, 3 o'clock in the morning or 2 o'clock in the afternoon. So even doing birth work, I'm sorry, y'all, I have children and they decided to make an appearance. Even as a birth worker, so if I have to, like trying to be a doula or doing placenta encapsulation or doing a childbirth education course, it's impossible for me to do those things, because then the concern becomes, specifically as a doula though, is that because it could run in conjunction with, son, I really need you to turn that water off, please, Tristen. I'm so sorry. As a being a doula, it makes it difficult because I have to be very specific about the clients that I take on to work with, because if I have 7 births with my preceptor in January, and then I take on a doula client, babies come when they come. So it becomes a conflict of interest, and you're really kind of like playing Russian roulette with birth, because it's like, do I decide to go here where my client is paying me because I need the money, or do I sacrifice my income basically to be present with my preceptor because I have to be there because I need these numbers in order for me to graduate? So considering this also is like childcare. If I have a birth I need to be at 3 o'clock in the morning, someone needs to watch my kids. I'm a single parent, so it's really difficult for me to find someone that can support being available to watch my kids, because then I have to wake somebody up at 3 o'clock in the morning to go drop them off, right? So it's just really hard. I don't have any family with me. I don't have any family around me. So I'm really doing all of this by myself. And I think the biggest thing also is that this puts a strain on my relationship with my children. I was a stay-at-home parent prior to being divorced and kind of still operating out of that space. But my kids miss their mom, and they tell me all the time. My oldest is always like, Mommy, I miss you so much. Like, I wish we could just hang out. And I'm like, me too, son, but I got to go do my homework. So it's really a matter of choosing between homework, going to clinic, hanging out with my kids, self-care, and work, which is non-existent, right? So, and I think what I've noticed too, as a Black student specifically, is that our level of support is really like non-existent. Like we don't there, and I'm not saying this for all of us, but in my experience, I don't have family around the corner where I can go drop my kids off. I don't have a mom or a dad. Like I have nobody that's near me that I can like, hey, can you watch your grandkids for a little bit so I can do my homework for 2 to 3 hours? I don't have that support, right? So these are things that I think in at least my community have been really difficult to manage in that regard. And then so as we're talking about this also income, it's impossible to work as a student midwife. Um, I think it's just like where do you find the time? I barely have the time to do my homework. So now having to juggle, how do I squeeze in a job in addition to schooling? I was working somewhere last year and I had to quit because I couldn't do it. And I was working overnight. That's the thing that made it even worse. I was working from like midnight to 8 a.m. Because that was a time when like my kids were asleep. I could escape the house for a little bit. You know, someone else was in the home that could just watch them until they woke up in the morning. So there was a certain level of availability there, but now I'm sacrificing my sleep, right? And then I have to be in my internship at 10 o'clock in the morning. So I'm literally getting home, taking a shower, brushing my teeth, maybe waking my kids up, trying to feed them, and I'm running out the door to try to go drop them off somewhere, right? But then if I don't have income, how am I able to support my kids and them having childcare? So this has been kind of like, you know, the biggest issue. And again, because I don't have family support, I have to find a job to be able to pay a babysitter. And I'm literally going to work so that my children have somewhere to go so that I can focus on doing my schoolwork. Yeah, and then so the last thing would be representation. The biggest hurdle that I face as a Black student midwife is the fact that I can't find us anywhere. I've had a Black preceptor once. I had a Hispanic preceptor at one point in time, and it did not work out very well for me. I think a lot of what I've recognized too in this space is that there's a certain type of privilege that's presented because they know that they are one of one. And so when sitting in that space of privilege, they can represent themselves in a way very much like gatekeeping. So not honoring the space. I understand, Foodie, but I'm on a meeting. I need you to put that down. No, no, I'm so sorry. So they're gatekeeping, right? So the trauma that they experience as a Black student, they're also now passing down to Black students. So rather than breaking this cycle, they are perpetuating the same cycle and energy that they experienced in their own preceptorships. And obviously this is a problem. And then even for the Black midwives that are available, one, they're super hard to find as it is. And then two, they don't want students. And then when you get them as a preceptor, they're abusive, or there's like microaggressions that you're experiencing. I know with the Hispanic preceptor that I had specifically, unfortunately, she was very racist. And she would make very microaggressive comments to me in front of me and other students and in front of the clients while we were in the clinical space. So as we're talking about navigating through midwifery school as a Black student, these are the things that I'm having to deal with on the forefront and that I'm consistently experiencing as a midwife, specifically because I'm Black. White students don't have these problems, right? So it makes it difficult to trust somebody to support you in your work, because I'm here specifically to help resolve these issues that Yuli and Tristen have talked about, because Black people need safe spaces to walk into. They need to be able to walk into these birth rooms and see that there is someone that is in there that looks like them, because there are so many cultural nuances that we as the Black community present, and we don't have the support in the room for people that look like us to feel safe with speaking our language, with saying things in the Black vernacular dialect, right? Like we have to code switch a lot. And so I'm here specifically to raise awareness and to create space so that Black women have places that they can have their babies, so that Black women have places where their kids can grow up and having the awareness of their bodies, autonomy, even their daughters, their sons, all of these things. Like, and we can't do that if, as Black midwives, we're creating barriers for Black and Indigenous and other melanated students to come up into this environment to create these safe spaces. So we have to fix that, right? That's the biggest thing here. And so I think one of the biggest resolution, obviously, is building up Black midwives. I have an awesome preceptor, and I'm surrounded by these phenomenal women. And no, she's not Black, but I love her to pieces. And when I remember when I walked in that birth center, I made it very clear to her that I know that I'm a Black woman, that these are the experiences that I've been having as a Black woman. And she stood behind me. She stood next to me, in front of me, all of the things. And she's been holding my hand through the process since December. And I love her. And then the other midwife that is also running that birth center, I love her to pieces as well. These women have held me and have made me feel safe as a Black woman, despite the fact that they are not Black. And what's so awesome here too is that there's 2 other student midwives. Well, there's 4 students altogether, but 3 of us are Black. And it's just awesome that this space, is specifically at Tourmaline Birth and Wellness in San Diego, has created a space to hold for Black students to feel safe and for us to operate in our Blackness. I don't feel like I have to be anything else but myself, and whatever that looks like in that space, right? But even in understanding that, it's important that for us as Black students, that when we grow up to be Black midwives and then we're qualified to be preceptors, that we uphold that space for future Black midwives, because we just do birth different. We do life different. And so we have to be able to create avenues for us to feel safe in doing that. I think in addition to that, the financial support is a really huge aspect of it. I think we need to figure out ways to get grants to help support student midwives in general, with things like little gas cards or just childcare or something, because that's a huge barrier to our success as student midwives, as well. So I know that we can't get paid, obviously, for going to our internships, but beyond that, just some sort of stipend or something to say like, hey, thank you for coming to this birth, here's $50. Like gas in California, I know y'all know. So we're just gonna leave that right there. Yeah, so like I said, the biggest thing, building Black and melanated midwives to become preceptors so that they can continue to carry on the legacy of building more midwives, so that we have safe spaces for representation for people that look like us, to know that when they walk into a room, it's like, oh, it's a sister in here, I'm gonna be okay. Yeah, because that's the only way that we're gonna create safe spaces. For us, of course, all of this information is super important in knowing how these stats add up, not even just across the United States, but specifically in California. But the biggest part of repairing that is creating more Black and Indigenous midwives. So we have to hold space for us. That is my portion. I'm so sorry again about my wonderful children making all kinds of appearances in the background.
Thank you, AJ, so much for sharing your experience. It's really important that us as midwives support student midwives, especially Black and Indigenous midwives, in order for them to become preceptors as well, right? So thank you again for sharing. So a recap of what we've talked about so far. The maternity care crisis that we're facing is directly due in part to racism and colonization, inaccessibility, and an overburdened system. I want to make it very, very clear that a person's race is not a risk factor for mortality. It is racism. It is the effects of colonization and racism that are deeply ingrained in the medical system and in medical education that is being taught. This system and this education is creating or just supporting racism and provider bias. Places need to really address and incorporate anti-racist and trauma-informed trainings. And it has to be more than once a year, more than just a check mark. And I can say that a local hospital, has had some issues. We've had some issues with. And we've asked them, are you doing anti-racist and trauma-informed training? And they say, yes, they do it once a year. But unfortunately, the practices and the experiences that us and our clients have discussed and experienced with them, it is not showing up in the type of care that they're giving. When we're talking about inaccessibility, it's more than just accessibility to a care provider. It is transportation insecurity, food insecurity, economic and housing insecurity. Paid family leave is, quite frankly, an entirely different webinar. And we need to be able to address each of these things in order to address the maternal and infant crisis and the maternity care desert crisis that we're experiencing. And number 3, an overburdened system. Our healthcare system is falling apart. There are closures happening all across California and the United States. There are doctors that are no longer practicing obstetrics and instead only focusing on gynecology. Practice is based in a fear-based way and a non-evidence-based way. And so we really need to work on continuing education and collaborating with midwives. So next slide, please. So solutions, like I said earlier, midwives are not the only solution to the crises that we talked about today, but they are a part of the solution. So next slide. So I want to quickly open up the chat and I want everybody to just respond in the chat box. In what ways do you believe midwives could help address the maternity care crisis? And while you're doing that, I'm gonna switch over to Yuli to talk some more about our call to action.
Thanks, Tristen. Thank you. So our call to action today is that we need better integration of access to collaboration with and expansion of midwives in all birth and reproductive health settings. So I hope that you all can think about the information that we presented today and also think about your local clinics, your local hospitals, your populations that you serve. How could midwives fill gaps? Specifically, licensed midwives. How could we fill gaps? And next slide, please. We have some ideas too, so I'd love to hear yours. You can drop them in the chat, or if you'd like to raise your hand to speak, if that's more accessible to you, please use that function. It should be on the bottom of your Zoom screen. But some ideas we have around filling gaps and utilizing midwives, licensed midwives specifically, is having better communications, especially around transfers, creating a seamless transfer mechanism between community birth and hospital birth if a transfer were needed or warranted. Having accessible referrals to high-risk OBs, MFMs, perinatologists. Those are really lacking and or very difficult for midwives to make. Mm-hmm. Yeah, he has lots to say about that. Okay. And we can also model off of other countries. There's plenty of other countries that have a well-integrated model of care that incorporates midwives. We can look to Ontario in Canada. We could look to New Zealand. We could look to the UK. These models exist and their outcomes are much, much better than ours. Like AJ was saying, expansion of midwifery, especially making midwifery school accessible to Black student midwives, to Indigenous student midwives, is so important. And one way to do that is to establish scholarship funds to ensure, if you're a preceptor, giving student stipends. Money. Student midwives need money to make this work accessible and equitable. And insurance coverage. We really need to place more urgency on our insurance payers to cover midwifery care. It is a lower cost. And also, we're going to see better outcomes. So it really makes sense for insurance payers to reimburse midwives fully, not just $2,000, $3,000, $4,000, but our full fee. So these are some ideas we have. Would our MC like to rattle off any answers from the chat that we've received about their ideas?
I did see one in regards to that question. Julissa Ruiz said restoring and revitalizing indigenous-based practices and communal care. Does anyone else like to answer the question that our speakers posed? The question was, in what ways do you believe midwives could help address the maternity care crisis? I seen one from Amina. Increase access to care, especially in underserved areas. Develop stronger relationships with patients and help to provide continuous care throughout prenatal period. It's a good one. Leslie says prenatal safe spots, providers, increase access. Hi, Leslie. Mia has, oh, she does not have her hand raised. Okay.
We can move to the next slide to open up the questions if anybody has questions.
So these are some resources that we want to share with you all. These resources will be shared in an e-blast that we will send out after this webinar. Next slide, please. Questions. I do see 2 questions in the Q&A chat, and then there is some questions and comments in the webinar chat. So I will start with the Q&A chat and I'll read that out loud. Someone said, are there foundations in California that support the field of midwifery? If so, what does that care cover? If not, has the field considered approaching foundations? Any of our speakers can answer that?
There are a few scholarship options in the state of California and nationally. However, it's often a lot of work, essay questions, reference letters. It takes a lot of time to apply for these things, and they usually end up being anywhere from 1,000, maybe 5,000, maybe one full scholarship for a midwifery student for the entire nation, right? That's not very accessible. It's not very equitable. We need to somehow get money in the hands of student midwives. Just no questions asked. We know that they are a tool to eliminating these disparities that we're seeing, and they need to be compensated equitably. They need to be able to access midwifery education so they can go and serve their communities. So some, but not a lot. We definitely need more. Here at ABC, that is one of our primary focuses, is uplifting student midwives, specifically Black and Indigenous student midwives. We are pending nonprofit status. So down the line, if you'd like to make a donation, send us an email.
Thank you, Yuli. One question from Micah Freeman. He says, how can we support you, sister, addressing AJ?
And AJ did
Yeah,
leave, sorry, AJ.
no, you're okay.
She did leave her email in the chat. if it's not available for everybody in the chat, maybe let's make that so.
Yes, I can. I can absolutely do that. You know, that's a hard but easy question to answer. I think the biggest thing is financially, life's just been really hard. I was going through a divorce last year, and decided to leave LA and move down to San Diego to just hit the reset button. And also, as I said earlier, the resources as far as accessibility for midwifery or preceptors, excuse me, in the LA area was really difficult. And when I came down here, I found a lot more options. I started at one place, which ended up not being safe for me, and then transitioned to Tourmaline. And I've had an awesome experience there. But as I stated earlier, income's just been really difficult. As I'm nearing the end of schooling, I have to find $1,500 to pay for this exam. Um, and yeah, just gas because I'm driving back and forth from San Diego to Marietta because I have an additional preceptor because my current birth center slowed down a little bit. So money is the most that I could ask for right now. And if you guys have any, resources for midwives in the area or some that might be willing to help me get my number so that I can finish on time, that would be awesome as well.
Thank you so much, AJ. There is a comment in the chat by Adriana. I'll read that out loud. It says, it's hopeful to see CHW doula benefits being recognized and administered to Medi-Cal members. Still just the beginning, but this could really be impactful for the community in accessing necessary resources.
Yes, and I hope it gets expanded in a way that includes midwives. We can take Medi-Cal as midwives, but the payout is very, very low and not sustainable for most midwives, unfortunately. So I know there are some organizations pushing forth to try to change that, but it is a slow process. And yes, doulas are great, CHWs are great. They are also not care providers like licensed midwives are. And having a clinical care provider that is from the community that can take Medi-Cal and be paid out in an equitable way would be huge. I think we would see much better outcomes if that were the case. So keep pushing for that.
Thank you. There was a comment.
Sorry,
Yes,
there's a question. I'm muted. Oh, there you are.
yes. Hi, Makai Freeman provided free pronouns here in Berkeley, California. I just want to make a suggestion, point of information. Whenever you can, as a student, please use your accommodation rights, where you can also request accommodations for extra time on exams as situations that may affect your schooling if you have disability. And under the ADA, it's a disability that affects one major life system. So that's very broad. From vision, hearing, mental illness, reproductive health needs. Please avail yourself of those rights. And also, I was wondering if the slides and recording and the chat will be shared out
after the meeting because I have a physical disability. Cannot take the notes in the slides in the chat. So thank you very much for this webinar. Thank you.
Thank you so much for sharing, Micah. And AJ, I just want you to know you're getting a lot of love in the chat. So please read through these comments and embrace it. And you're wonderful as well. If anyone else has any more questions, feel free to reach out to the speakers. We'll share their contact information at the end of this webinar. Next slide, please. So we want to thank you all for joining us today. And I'll have Lisa input the evaluation in the chat. We want to get your feedback on how this presentation went. Your thoughts are very important to us. And by filling out this evaluation, you will be entered into a raffle. So we'll pick 3 winners from the evaluation who will receive a $50 check. So please fill out that evaluation if you can. Thank you. So today, this was our second webinar of the webinar series. And we have our last one, which is the Know Your Rights webinar, which will be Thursday, October 17th from 3:30 to 5. We will be discussing birth rights, FAQs on birth justice, and overcoming barriers to birth equity for birthing families of color. And we will put that information in the chat as well. That will be our last webinar series, so we would love to see you all there. The Whole Child Equity Partnership is having a webinar on reparations, and this is coming from our Economic Security Work Group. So this webinar will be on how does prenatal to 3 fit into the whole reparations conversation. This webinar will take place Tuesday, October 8th at 10 to 11 a.m. And we'll be discussing the history of reparations in the current context setting and the historical context of racial injustice, systematic racism, reparation efforts, and strategies. And we hope to see you all at that one as well. And last but not least, thank you so much to our panelists. Our speakers, you all did amazing, a lot of wealthy information. Please take a screenshot of this slide. This is our speakers' contact information. I'm sure they'll love to hear from you with any questions or comments that you need. So thank you so much. And that is the end of our webinar.